we recently highlighted a paper that demonstrated that the missed cancer rate in upper GI endoscopy, which is defined as a patient being diagnosed with an upper GI cancer within 3 years of their last gastroscopy, is 10%. Now, this isn't entirely shocking because it is entirely consistent with other previous work on this subject and goes to show that there is a very high missed cancer rate in upper GI endoscopy. I'm always a little bit surprised by how little attention this gets when compared to the missed colorectal cancer rate in colonoscopy. And in fact, we know that this missed rate in colonoscopy is lower. Great work has been done in the world of colonoscopy to improve quality endoscopy. And this includes things like more attention being paid to bowel prep to ensure adequate mucosal views, a withdrawal time being mandated at 8 minutes, and of course an adenoma detection rate being monitored in each individual to ensure that each individual is keeping their quality high. This has resulted in the miss rate in colorectal cancer falling, and the current stats will tell you that depending on which paper you read, and of course the pathway of which the patient presented, the missed cancer rate in colorectal cancer is somewhere between 2 and 8%. So despite the upper GI missed cancer rate being higher, we don't focus as much on how to improve these outcomes. There have of course been papers published around this subject, and particular note should be made of the ESGE guidelines published in 2016, which outline quality indicators in upper GI endoscopy. So looking at this paper and looking at the other papers around this subject, here are those top tips from these papers. Firstly, sedation. Now this may be more of an issue in the UK rather than in the wider world, but in order for us to visualise the upper GI mucosa properly, a patient is going to have to tolerate a procedure that could last up to 10 minutes. There are very few patients that can tolerate an upper GI endoscopy without sedation that lasts 10 minutes. Retching and gagging means that we have very limited views of the stomach or the gastroesophageal junction, which of course will lead to missed lesions. I'm always quite surprised that we accept a poor quality procedure, and obviously I make sure that my patients are well sedated. Secondly, one must ensure we get adequate mucosal views. Therefore, of course, we have to send correct fasting instructions to all our patients. But a good tip is to also offer patients a small drink of Infocol prior to their procedure, which decreases the amount of bubbles and saliva that one finds in the stomach and again improves views. This doesn't mean, of course, your work's done, and when performing the endoscopy, we need to ensure that there's adequate washing so that you can see the entirety of the mucosa. This means washing with Infocol, N-acetylcysteine and antimucolytic, and of course water. We wouldn't accept poor views in the colon, but yet we seem to accept them within the upper GI tract. Thirdly, again, just like in colonoscopy, you need to ensure that adequate time is spent examining the upper GI tract. The data will tell you that the procedure needs to be at least 6 minutes in duration, if not more, and that will increase your dysplasia detection rate. Therefore, a gastroscopy should certainly not be quicker than 6 minutes. We also know, of course, that in Barrett's esophagus, we need to spend at least 1 minute per 1 centimetre of Barrett's esophagus in order to perform adequate examination. So again, time is key. Photo documentation, of course, needs to be far more rigidly observed in the upper GI tract, just like in colonoscopy. We wouldn't ignore a picture of the cecum or a picture of the appendiceal orifice, but yet in the upper GI tract we seem to stick far less rigidly to photo documentation. As per the ESG guidelines, one should be taking 10 pictures of the various stations within the upper GI tract to demonstrate that we've obtained adequate views. Finally, lesion recognition in the upper GI tract is more complex than in colonoscopy, and it does take time to learn. One needs to be confident with the size of squamous neoplasia, predominantly using enhanced imaging, that is looking at the IPCL pattern. We need to be confident picking up Barrett's neoplasia and therefore looking at the mucosal patterns, nodules, ulcers, any vascularity changes. Can we detect atrophic gastritis, that is a whitening, the pallor, the visible vessels, and then looking for little subtle signs of intestinal metaplasia, the change of mucosal pattern. We need to know what gastric polyps are relevant, and of course we need to be able to detect gastric dysplasia alongside many other pathology. Therefore, one has to perform an upper GI endoscopy utilising image enhancement. The data will demonstrate that using image enhancement does improve our early neoplasia detection, and therefore on all patients I make sure I use image enhancement, and I always intubate the esophagus on white light, and regardless I'll always extubate the esophagus using my enhanced imaging. And as this video will show, that helps you pick up early subtle squamous neoplasia in particular. So, in summary, we are missing lesions in the upper GI tract, and that's for a variety of reasons. But really crucially, it comes down to two things: time and knowledge. Both of these factors are, of course, in our hands. So, look at our knowledge centre. Look at the early signs of Barrett's neoplasia or squamous neoplasia, or look at how to detect atrophic gastritis, and ensure you're adequately prepared to pick up those early lesions.